I'm happy that we have the opportunity to present some updates here in the CNS tumor field. Now, following the standards of care, I'd like to embark a little bit on some new developments, and probably many of you would expect that we are talking about many exciting and fancy data, which unfortunately, as you will see, is not always the case. Immunotherapy and targeted agents are clearly an interesting area, but as many of you will know, unfortunately, it's also an area with various failures and negative trials. Now, let me start with a brief overlook on immunotherapy in neuro-oncology, focusing on the glioblastoma field. In the last 5 years, we have seen several negative phase 3 trials, exploring different types of vaccinations, targeting, for example, the mutant variant of the EGF receptor. This trial was called ACT4, and another trial explored a dendritic cell-based vaccine, unfortunately largely unsuccessful. There's a negative phase 3 trial with a so-called immunotoxin. This is an antibody, again, recognizing EGF receptor, which is coupled to a toxin, and following some promising data from smaller trials, the phase 3 trial was unfortunately negative. There are new developments like oncolytic viruses. They are here summarized under immunotherapy because they are supposed to elicit an immune response against the tumor. And there are several approaches using engineered immune cells, for example, CAR T cells, which are now also used in the context of brain tumors. But to make it very clear, we are talking about things which are in an early stage of clinical development. So a major focus in the last years has been immune checkpoint inhibitors. These are drugs like CTLA-4 or PD-1 or PD-L1 blocking agents, which have been used with great success in other fields of clinical oncology like melanoma, lung cancer, and other cancer types. So there was also a strong interest in exploring these drugs in glioblastoma. And so far, we know the data from one randomized phase 3 trial called Checkmate 143. This is a randomized 2-armed trial for patients with first recurrence of glioblastoma. And as you see, the PD-1 inhibitor nivolumab was tested against bevacizumab. Trade name is Avastin. And these are the key data of this trial. There was a difference in progression-free survival shown on the left, favoring bevacizumab. Those of you who are familiar with this drug won't be too surprised because we know that bevacizumab has a strong effect on the contrast uptake in imaging. So it was clear that it would be very difficult to be better than bevacizumab when it comes to progression-free survival. But what is rather disappointing is the result in terms of the overall survival. There is clearly no difference between the two treatment arms. So overall, this is unfortunately a negative trial. And then, of course, there were some efforts in finding subgroups of patients which may still have a benefit. And the hypothesis was that mainly patients with tumors that have a high mutational load and patients who do not need steroids when they entered the study might be those who have benefit from this kind of immunotherapy. And in fact, patients with MGMT promoter methylated tumors, these are the patients who typically have a long exposure to temozolomide and in parallel not requiring steroid treatment when they enter the trial. So at baseline, these were the patients who had the longest overall survival when they received treatment with nivolumab compared to all other subgroups. But to make this clear, these are small subgroup analyses which do not prove anything. They are hypothesis generating at best, so it would need further studies, larger trials to demonstrate that there are truly glioblastoma patients who have benefit from nivolumab. Many trials are ongoing, some of them using checkpoint inhibitors in the first-line treatment, in addition to radiation therapy and temozolomide chemotherapy, or combining checkpoint inhibitors with other immunotherapeutic strategies, for example, vaccination. So it needs to be awaited if there is a place for these drugs in the glioblastoma field. Now let's get one step further, something which has gained a lot of interest in the last years, but not necessarily in the glioblastoma, but rather lower grade glioma field are IDH mutations. All of you know that IDH mutations are very important in these days when it comes to the classification of gliomas. They are very frequent in grade 2 and grade 3 tumors, and according to the newest classification, only IDH wild-type tumors are now considered as true glioblastomas. Now, the presence of an IDH mutation in a glioma cells has many biological consequences. It changes the whole biology of the cell, and the key point is shown here. The mutation in the IDH enzyme results in a different metabolite, which is called 2-hydroxyglutarate, compared to the physiological metabolite, which is alpha-ketoglutarate. And 2-hydroxyglutarate impairs several processes within the cells and has also an impact on infiltrating cells in the tumor microenvironment. Now, why is this therapeutically interesting? There are at least 2 novel therapeutics to interfere with this mutant variant of IDH. One are pharmacological inhibitors of the mutant IDH protein. These are the IDH inhibitors shown here, and many companies are working on these drugs. And the second strategy is exploiting mutant IDH for vaccination approach. What do we know about the pharmacological inhibitors? There are several compounds available. One of the clinically most advanced is called ivosidenib, which was tried in a phase 1 trial in patients with IDH mutant gliomas. And first of all, it's encouraging to see that the administration of ivosidenib, of this IDH inhibitor, to glioma patients resulted in a strong decrease of intratumoral 2-hydroxyglutarate levels, which shows that there is apparently sufficient target inhibition. The drug is overall well tolerated, and as you can see from these waterfall plots, at least in patients with non-contrast enhancing tumors, there was a stabilization of the disease or even a reduction in the size of the tumor in a significant fraction of patients, whereas the data looked less encouraging in patients with contrast-enhancing tumors. And the clinical development of ivosidenib and closely related drugs is currently ongoing. The second approach that was mainly developed by the group of Michael Platten in Mannheim in Germany tries to establish a vaccination against the mutant form of IDH. The idea behind is that these IDH mutations are only present in tumor cells, but not in healthy tissues. So theoretically, mutant IDH should be an ideal target for such a vaccination approach. And such a peptide vaccine was now explored in a first phase 1 trial. It was well tolerated. There were several imaging findings which were considered and interpreted as pseudoprogression, in other words, an inflammatory reaction following the vaccination. And there were mainly measurable immune responses in the blood, and this is shown on the right on this diagram. It's a bit difficult to understand. Every column is one patient. A black field means that there is no measurable immune reactivity, and you have to read it from the top to the bottom. Green, and particularly red, means that there is an immune response to the vaccine. And as you can see, in the vast majority of patients, there was such a measurable humoral or cellular immune response. Again, this is a promising finding, but it does not tell us yet if there is any clinical activity. exerted by this vaccination, and this needs to be tested in larger and future trials. Now let's get again a step further to the what I would consider classical targets for a targeted treatment approach. These are either receptors or molecules that are either exclusively or at least highly expressed by glioma cells. There are also several pathways which are well described to be overexpressed and overactivated in glioma cells. Some of them are shown here. And one key question has always been, does it make sense to target only one of these genetic alterations or one of these pathways? And wouldn't it make more sense to target somehow all of them? And one approach that was considered of interest is to target the proteasome, because the proteasome is kind of the cellular's garbage can, which means the proteasome is important to remove proteins which are no longer required by the cell. And if the proteasome function is inhibited, this should severely disturb the cellular function. This approach works quite well in other types of cancer, for example, multiple myeloma, where we have several clinically approved proteasome inhibitors. However, these drugs do not cross the blood-brain barrier. And in this regard, it was considered of interest that a new drug emerged, a new proteasome inhibitor, which is named marizumab, which irreversibly inhibits with the function of the proteasome, and in contrast to many other similar drugs, also crosses the blood-brain barrier. And following smaller trials, a phase 3 trial was now designed to explore marizumab in patients with newly diagnosed glioblastoma, a 2-arm trial comparing the standard of care alone with the standard of care plus marizumab. Roughly 750 patients were enrolled in Europe, in Canada, and in the US. And the results were recently published at the ASCO meeting. And unfortunately, as you can see, there is no difference in overall survival between the two treatment groups. There was also no difference in progression-free survival. So again, unfortunately, a drug which seems not to be active in glioblastoma. Another approach which tried to interfere with several of these pathways here was explored by colleagues in Italy. There's a drug which is known as regorafenib. This is a so-called multi-kinase inhibitor, and it acts on various receptor tyrosine kinases and receptors that are expressed on the surface of glioma cells, which then activate several downstream signaling pathways which are involved in several key aspects of tumor cells, leading to tumor cell survival, tumor cell growth, and so on. And interfering with all these pathways obviously would make a lot of sense and may exert strong anti-tumor activity. The drug is approved in different types of cancer and was now tested in a trial for patients with first recurrence of glioblastoma, 2-arm trial. Regorafenib was the experimental group, and lomustine, which was already mentioned by Andreas Hottinger, was kind of the standard of care for these patients with first recurrence of glioblastoma. And the results are quite interesting. There's a small but not really exciting difference in progression-free survival, still significant. But even more interestingly, there was a quite striking difference in overall survival with a quite impressive hazard ratio, as you can see here. This is also statistically significant. So this is formally a positive phase 2 trial. Now, there are still some discussions, or you could even say concerns about this trial, and this becomes clear when you look at the absolute numbers. The median overall survival for the lomustine group, for example, was only 5.6 months, and as shown before by Andreas Hottinger, this is clearly below the expectations. Typically, you see 7 or rather 8 to 9 months with lomustine in large phase 3 trials. Of course, this was a randomized trial, no reason to believe that anything went wrong here with the randomization, but still many people, including myself, believe that this result needs to be confirmed in a larger trial, in a phase 3 trial, to really demonstrate that regorafenib is superior to lomustine, and such a larger trial is now ongoing. So at least an encouraging finding, but it needs further confirmation. Now, there are some more specific approaches with drugs that act specifically at some defined molecular alterations, and you will know that such drugs have been approved for other types of cancer, for example, against FGF receptor fusions, or particularly against NTRK fusions. Such NTRK fusions are overall very rare in most cancer. There are just very few rare tumors where they are frequent, but in high-grade gliomas, for example, they are really rare and found in less than 5% of all tumors. There is a series that was presented 2 years ago at the ASCO meeting, mixing up pediatric patients and adult patients suffering from different types of gliomas. You can see it here. There were glioblastoma patients, but also patients with lower grade diffuse gliomas or circumscribed gliomas. And all these tumors harbored one of the well-known NTRK fusions, and these patients were eligible for this trial. And the results were, I would say, promising. Roughly 1 out of 3 patients had a response, with some patients having partial responses and 2 patients even having a complete response. 9 patients had stable disease. So overall, there might be some clinical activity with such NTRK inhibitors in patients with NTRK fusion positive gliomas. Again, these are data from a small series, and they need to be confirmed in larger studies. And finally, probably the best example we have so far for a targeted treatment is for the so-called BRAF inhibitors. BRAF mutations are well known, for example, in the melanoma field, where several BRAF inhibitors are clinically approved, and there's now one series with 24 patients, again, rather heterogeneous. You may know that BRAF mutations are quite frequent, for example, in pleomorphic central astrocytoma, or also in ganglioglioma. They are rare in glioblastomas. Roughly 5% of all glioblastoma harbor such a BRAF mutations. But if you find this activating mutations, you may see some striking clinical activity. This is one example of such a young patient with a BRAF mutant recurring glioblastoma in the left temporal lobe, which was growing very quickly here within 4 weeks, a significant growth of the tumor. And she was then started on vemurafenib, which is such a BRAF inhibitor with a very nice, almost complete response here, which lasted for more than 1 year. And then the tumor recurred. In other words, it's not possible to cure these patients, but still we see quite impressive responses and a stabilization over a significant period of time. To sum this up, what we know so far is that immunotherapy is not active against glioblastoma. There are several negative phase 3 trials with vaccines, with checkpoint inhibitors, and so on. But there are even more ongoing trials with with additional checkpoint inhibitors, either alone or in combination with a standard of care or with other immunotherapeutic approaches. There are novel concepts, I would say better concept with vaccines, which are personalized, customized based on the individual patient's tumor tissue. And then there are, of course, early trials with engineered immune cells or oncolytic viruses, as I briefly mentioned. Targeted therapies, and this seems to be clear, are probably not working in a group of unselected patients. There are again several negative phase 3 trials with various targeting agents. There is a bit of light at the horizon with regorafenib, with this positive phase 2 trial, which requires confirmation in a larger trial. And then for subgroup of patients, which are rather rare, but which can be found, it may be worth to do a treatment with targeted agents such as NTRK or BRAF inhibitors, and these patients may have clinical benefit from these drugs. With that, I'd like to finish. Again, sorry for the technical issues, and I'm happy to take questions.
Thanks a lot, Dr. Roth. Well, at the moment, we don't have any questions from our audience, but if we have any, of course, we will refer them to you. Thanks a lot.